Amyotrophic lateral sclerosis, or ALS, is a progressive neuromuscular disorder that is fortunately very, very rare. Although I have a colleague, a nursing colleague, who was diagnosed with ALS of the bulbar kind, and so it's rare, but that doesn't mean you won't encounter somebody with the disease. In terms of time that spent on it, I will devote, I guess I would say, a shorter amount of time to this disease because of its rarity, although you need to know what the nursing focus would be in the care of patients with ALS if you encounter them. I'll let you review the pathophysiology of it. It is a result, the disease or the clinical manifestations occur because motor neurons degenerate in the brainstem and in the cord, and we don't even exactly know why they degenerate or why they die off. But when they do die off, of course, then there is not going to be enough nerve impulse transmission to support the movement of the muscles, and so the muscles are affected. Um, up to and including the muscles of respiration, which typically means that the patient is going to have increasing paralysis and ultimately die. I find it interesting that your textbook in the section on ALS mentions Stephen Hawking, who they describe as in his mid 70s and still alive, but of course he just recently died finally. But stayed alive for a very long time, 50 years, with the disease, with excellent support, and of course being ventilator dependent for a lot of years. The difficulty, of course, with ALS is while the paralysis gets worse, leading to potential dependence to mechanical ventilation, the mind is unaffected, and the sensations are unaffected as well. This is a motor disease. Um, and we're going to start with with this video at the clinical manifestations. Initially, weakness, and then in paresis, and then paralysis, which of course, depending upon the muscles that it involves, can affect the muscles of ambulation, lower extremities, upper extremities, and along with with degeneration of the muscles comes muscle wasting, fasciculations, which are little involuntary contractions of bundles of the muscle. There can be spasticity and pain that goes along with this. As the muscles of speech and swallowing are affected, then of course dysphagia and dysarthria, and even sleep disorders that can occur, and as the slide says, ultimately the muscles of respiration with death. ALS doesn't have a specific diagnostic test like so many of the conditions we've been talking about here in this lesson, the neuro lesson. So it's a diagnosis of exclusion. Everything else is ruled out. A literal battery of diagnostic tests may be done, including the electromyogram, nerve conduction velocity test, where they can measure the speed of conduction of the nerve, of neuromuscular impulse conduction, MRIs, lumbar puncture, where the cerebral spinal fluid sample is taken and analyzed, a myelogram of the cervical spine to see how the cerebral spinal fluid moves, and then muscle and nerve biopsies to see if there are visible signs of the degeneration of the muscles, and also genetic testing, because there are some known genetic abnormalities that can cause familial types of ALS, and so it's useful to do that in an attempt to find out if if this patient has a familial strain or variety of ALS. The care, as you might imagine, for somebody with such profound symptomatology and so many body functions affected is going to be interdisciplinary. There is one drug. There's no cure, but there is one drug that that has been found to slow the progression of the disease, riluzole, trade name Rilitech, which decreases the levels of glutamate in the brain, and excessive levels of glutamate are implicated in the as the contributing factor to the degeneration of the muscles in ALS. But if this decreases the levels of glutamate, then it's been found that it can slow the progression of the disease and by reducing the damage to the motor neurons caused by the glutamate. Lots and lots and lots of supportive care therapies, including PT and OT, in order to manage the spasticity of the muscles as they degenerate. Adaptive equipment, assistive devices, careful positioning during eating, nutritional support to change the consistency of the food to make sure that the person gets calories but is at reduced risk for choking, aspiration. Ultimately, intubation, or if not, more likely because it's likely to be chronic, placement of a tracheostomy, a breathing tube directly into the trachea, and use of mechanical ventilation and motorized wheelchairs, and just a tremendous amount. The home environment may need to be altered. 24-hour care may be required. You can just imagine how many people can be involved in the care of a person with ALS. And a death can occur in just a few years, but of course we have some examples of people surviving for decades with ALS. So imagine the impact of having ALS on a person's ability to move, to work, to participate in family life. Imagine the effect on the emotions and what's required to cope with such a radical disease, and then imagine the impact on family members and caregivers, family caregivers that are involved. Nursing diagnoses, I kind of frame these in a little bit more of a positive light. With some of our nursing diagnoses are very positive in that they acknowledge that people are ready to become fully engaged in managing their disease, in learning about their medications and how to safely take them, in participating with the therapies, in just adhering to the best of their ability to their treatment regimen, but risk for injury, risk for falls, airway concerns, breathing concerns, and so on. So the goal is supporting maximum function as long as possible. And I've mentioned a number of these interventions already, except I didn't really talk about communication devices. When somebody with ALS has such dysarthria that their speech is incomprehensible, or they lose the ability to speak, there are technologies that can facilitate communication in this day and age. What if they can no longer safely swallow? Then placement of a feeding tube, like a PEG tube, percutaneous endoscopic gastrostomy, or PEJ tube, which can provide nutrition, enteral nutrition, but bypassing swallowing. I mentioned positioning to reduce the risk of aspiration, watching carefully their respiratory status and providing ventilatory support when it's needed, managing the pain that can come from spasticity or fasciculations, and keeping them safe. Referrals, very, very useful to support groups and sources of information. There can be pretty high tech supports here for people who have ALS. I mentioned intubation or a trach placement with mechanical ventilation, but people may even have with ALS, in order to help support good respiratory function, may have high frequency chest wall oscillation as a therapy. One brand of a vest that you put on your chest that provides this external high frequency chest wall oscillation is called the vest. This is useful to help people with ALS remove their respiratory secretions. And non-invasive ventilation may be used, like CPAP, BiPAP early on, and then ultimately TIV or tracheostomy invasive ventilation might be used, which I've mentioned. Caregivers are going to need a lot of support. End-of-life decision making needs to be done as soon as possible for people with ALS, because you can't predict the progression of their disease, and a decision will need to be made as to what kind of support is acceptable for the patient and family. And then, as it's apparent that they are approaching the end of their life, lots of support for anticipatory grief as the patient and the family members anticipate the impending death of a patient with this disease. This is a disease where nursing a good, basic nursing care is so important to the quality of life of the patient and the caregivers.